Hi, everyone. Welcome to Grand Rounds. September 13th. Here's today's CME, and there's a little CME slide coming about why you don't get any responses. Guess what? It's broken. So today is the start of Friday is the start of National Hispanic Heritage Month. It must be the only one that goes through 2 months. I didn't realize it was a 15th to 15th thing. Rosh Hashanah starts Friday. September is also Dystonia Awareness Month, World Alzheimer's Disease, and Women in Medicine Month. We're still working on our Women in Neurology lanyard. It should be coming in the next month or 12. Who knows? Okay, so Duke is requiring a flu vaccination starting September 21. That's the same every year. Interestingly, a COVID vaccination is not required this year. But I would say everyone should get it because I think we all know lots of people who've had COVID over the last 3 to 4 weeks. It seems to be everywhere. Today's National Peanut Day, International Chocolate Day, and National Positive Thinking Days, all good things. I was surprised to see it's also National Hug Your Boss Day, which I think should be retired as a national day. Please do not hug your boss. And if you're a boss, do not hug anybody. 2 did you knows? The highest recorded temperature on record is 134 degrees, Death Valley, California, which seems to be between Los Angeles and Las Vegas, so don't get stuck there. The oldest known living person is 116 years old. She played the piano till she was 108. The oldest living known man is 114. It turns out amongst the 100 oldest women and men, women live 3.2 years longer than the 100 oldest men, which is probably not surprising. Here's our CME update. The system's not working, as everyone knows, but they promise us that you're still getting credit if you send your number. But the problem is you won't know if you're sending it into the wrong number or if you entered the wrong. But enter it anyway, and you'll get CME credit, they tell us. Our research symposium is next week, September 21st at the Great Hall. Everyone is welcome to supply a poster. Some research roundup. Berkowitz, our new faculty member, and Tamir Abgadar were the senior authors on a study looking at the interaction of sleep oscillations and memory in patients with drug-resistant epilepsy. Deb Kotai was part of a group characterizing the burden of epilepsy amongst older patients in sub-Saharan Africa. Sveta Sengupta and Jaskan Vidwan were an article looking at the overlap between migraine and idiopathic intracranial hypertension. And our all-star is Christine Givis and River Jordan, nominated by Dylan Ryan, who talked about a patient with an LVAD. Duke is like the top LVAD place in the country. I mean, half of people here seem to have LVADs. You see someone with a briefcase, it's an LVAD. Her NH score went from 8 to 2 with endovascular therapy, and she's doing great now. So congratulations to everyone. And again, this is our CME code, and our case presentation is done by the great Stephanie Reyes. Let me get out of this, stop share. The S thing. Stephanie, which one is you? Is that the food? Or is it stroke? It's 3 stroke code. Or a stroke code, yeah. It's either food or a stroke code. The food is out there?
Yeah, we need to put the early bird in between Chick-fil-A's.
That's not our Chick-fil-A.
No, but the early bird is there.
Then what's it?
Oh, that's all.
I'll give it a second.
So we set it out so the surgeons could have even more food. Yep. Oh. Take it away.
Alrighty. Hi guys, I'm Stephanie. I'm one of the third-year neurology residents.
Floating controls, just go up to there, more. Floating in.
Okay. And today I'll be presenting the case presentation on a, let's see, how do I move it?
Mouse and then-
Okay. I'll be presenting on an 85-year-old female with a history of dementia, heart failure, coronary artery disease, hypertension, and chronic kidney disease, who presented with 2 to 3 weeks of a new diffuse desquamating rash, altered mental status characterized as disorientation and decreased alertness, as well as diarrhea and some concern for seizure. The next slide are several images of the rash, just a fair warning. So as you can see, the patient exhibited a rash that involved their head, their torso, and all of their extremities. By the time we saw her, the rash was actually much improved from its onset, but still remained fairly painful for the patient. She was evaluated by our dermatology colleagues that performed a skin biopsy that revealed a spongiotic dermatitis. The rash in itself was undifferentiated, but they suspected that it could have been related to a drug reaction to ondansetron or acute generalized exanthematous pustulosis. We were consulted for concern for altered mental status, as well as concern for new seizure. The episode in question was described as the patient was bathing and subsequently was found to have tonic movements or tonic stiffening of her bilateral upper extremities and lower extremities that progressed to clonic movements that lasted 1 to 3 minutes with continued altered mental status following the episode. When we arrived, she had a very limited neurologic exam given her mental status. Her GCS was a 10, E4, V2, M4. She was unresponsive, did not follow commands. She grunted to painful stimuli. Her eyes spontaneously opened, but otherwise we couldn't evaluate much of her cranial nerves. She had intermittent rhythmic jerking in the bilateral upper and lower extremities. They were seen to be finger flexion, wrist flexion, supination, as well as elbow flexion, more notable on the right than the left. And she had normal reflexes with no clonus at the ankles, but this was limited by frequent jerking and some peritonia. In terms of her diagnostic workup, we recommended an MRI brain with and without contrast to evaluate for a structural abnormality that could have caused her altered mental status and new seizures. This was limited by motion artifact, but from what we could see, there was no acute intracranial abnormalities. Her EEG was notable for abundant right-sided spikes that then evolved into electrographic seizures and clinical manifestations of those seizures as well. She had a fairly extensive serum and CSF workup. Her CSF did not show a pleocytosis. It was pretty bland. She had sort of toxic metabolic infectious workup, including HIV, syphilis. Inflammatory markers were elevated, but she had a series of vitamins checked as well to see if that could be related to her presentation. Some of her vitamins were in the normal range and some were in the low normal range. A vitamin B3 or niacin was sent given her dermatitis, and it was actually found to be low. So given her dementia, dermatitis, and diarrhea, she was diagnosed with pellagra. The primary team asked us if the pellagra could also be the cause of her seizures. We thought it to be unlikely. It recommended that they send vitamin B6. And when this vitamin B6 was sent, it was also low. So I just wanted to talk very briefly about vitamin B6 and how it lowers the seizure threshold. It's actually a very simple pathway. It's involved in the production of GABA from glutamate. It's a cofactor. And when you have a reduction in B6, you have a reduction in GABA, which is an inhibitory neurotransmitter that then results in a decrease in the seizure threshold. So fairly simple pathway to remember. And we wanted to send a vitamin B6 because it's actually a cause for vitamin B3 deficiency. Vitamin B6 deficiency or vitamin B6 is actually involved in the synthesis of vitamin B3. This is sort of a busy slide, but tryptophan is an amino acid that an essential amino acid that we get in our diet. It's converted into serotonin and melatonin, but it's also converted into NAD+, which is synthesized from vitamin B3. And to do that, we need vitamin B6. So effectively, when you develop a vitamin B6 deficiency, it predisposes you to seizures, but also predisposes you to vitamin B3. And in this patient's case, can predispose you to pellagra and the manifestations of it. So going back to the case, the patient was initiated on vitamin B3 and B6 supplementation. She continued to have altered mental status and diarrhea, but had some improvements in her seizures after initiating Keppra and Depakote and after starting vitamin supplementation. After 5 weeks in the hospital, she transitioned to comfort care and passed away. Just some takeaways. I just wanted to remind everyone about the 4 Ds of pellagra, which were demonstrated in this patient, unfortunately. And that's dermatitis, diarrhea, dementia, and death. Secondly, vitamin B6 deficiency can cause vitamin B3 deficiency. And lastly, vitamin B6 deficiency lowers the seizure threshold. I think for a lot of us, for kids, we send a lot of vitamin B6 because we suspect it to be often the cause of some of their new seizures, and they sometimes have seizures that are responsive to vitamin B6 supplementation. But we oftentimes don't think of adults with new onset presentations of seizures and possible association with vitamin B6 deficiency. So that's my case. Thank you. Yeah.
Good morning. I would also like to welcome our guests from the Duke Global Health Institute who are here in person and on Zoom. Today is my pleasure to welcome Dr. Aaron Berkowitz for today's Grand Rounds. Dr. Berkowitz is a professor of clinical neurology at UCSF, where he serves as a neurohospitalist, general neurologist, and clinician educator. He completed his residency training at Harvard Medical Center, where he went on to become associate professor as well as director of global neurology. He has served in leadership positions with Partners in Health, as well as Doctors Without Borders, winning awards for his global health work from the American Academy of Neurology, as well as the American Brain Foundation. He has also received multiple awards in education from the Harvard Medical School and is active on the podcast Clinical Problem Solvers, as well as publishing popular neurotweetorials on Twitter. He also holds a PhD in classical piano, which he completed during a detour from medical school. He is on the editorial board of Continuum, has authored 4 books, and published over 80 peer-reviewed articles. I personally recommend his book, One by One by One, about his extraordinary work caring for patients with brain tumors in rural Haiti. Please join me in welcoming Dr. Aaron Berkowitz.
Should I stop share? And yeah. All right, let's see. Oops, thank you. Set? Yeah. All set? Great, well, thank you very much for inviting me here to Duke and for that generous introduction. Great to meet so many residents and colleagues at dinner last night. Look forward to the rest of my day today here at Duke, and happy to talk to you a little bit about global neurology. So when people think about global health, they don't typically think about neurologists, right? They think about infectious disease doctors swooping in to fight the latest outbreak of some tropical disease, or think about surgeons swooping in to repair all the cleft palates in some remote region of the world, and then think of neurologists and say, well, you all don't really swoop, do you? And our stroke and critical care colleagues aside, right, that's largely a fair assessment. We take care of patients with chronic diseases that require complex diagnostics and equally complicated treatment. So when you start thinking about neurology in a global and particularly in resource-limited settings, it leads to a number of dilemmas. So after a brief introduction to the field of global health and global neurology, I'm going to frame my talk with reference to a number of dilemmas I face predominantly in my work in Haiti. So in 2004, the WHO and the World Federation of Neurology did a survey looking at the number of neurologists in each country in the world. And so the countries in light blue and dark blue have at least one, and in many cases, more than 5 neurologists per 100,000 population. And on the other extreme, the countries in pink, and probably the ones adjacent to them in white where there was no data, had fewer than 0.1 neurologists per 100,000, or fewer than 1 per 1 million. So on average, in high-income countries like the US, there were 3 neurologists per 100,000 population, and the number dropped by a factor of 100 to 3 neurologists per 10 million in low-income countries. So imagine just 3 neurologists for all of Manhattan, or 3 neurologists for all of Los Angeles County. Now, this was in 2004, and one would hope that over 20 years, these numbers have improved. And when this was repeated in 2017, the numbers did improve in high-income countries where we now have almost 5 neurologists per 100,000 population. But in low-income countries, the number was static at 3 per 10 million. And if you think about it, if you were just one of 3 neurologists per 10 million population, probably wouldn't have time to start and run a residency program and train more neurologists. And so medical students in countries with fewer known neurologists often leave their countries to study neurology elsewhere, and through the brain drain are relatively unlikely to return. So when I present these data, some people say, well, isn't it a tragic truth that in the lowest income countries, people don't live as long? And if the lifespan is shorter, maybe people aren't living long enough to have their strokes and develop dementia and Parkinson's, and maybe you don't need as many neurologists. Maybe you should be training more pediatricians as opposed to neurologists. So let's look at the other side of the coin and some data on the global burden of neurologic disease. So data from the Global Burden of Disease study, which is a huge epidemiologic study, but also uses statistical modeling to fill in gaps where there are no particular epidemiologic studies or public health data. So these are estimates. The study, when it was published in 2016, said that only 4% of global deaths were due to neurologic disorders, so a relatively small slice of the pie. But if you look at the fine print of this paper to see what they include, they have dementia, epilepsy, Parkinson's disease, motor neuron disease, multiple sclerosis, and other. All important diseases, but a couple things missing, right? So what about stroke? Stroke accounts for 11% of the global burden of mortality. It was classified as a cardiovascular disease in this study. I think everyone in this room would agree neurologists are pretty helpful in the diagnosis and treatment of stroke. So I'm going to repatriate stroke back to our pie chart in neurology. What about meningitis and encephalitis, classified as infectious diseases, nervous system cancers under oncology, tetanus, cysticercosis, dengue, and rabies classified as neglected tropical diseases, which is true, but that all cause their morbidity and mortality through neurologic pathophysiology. Add these all up, and now the global burden of neurologic disease accounts for 17% of the global burden of mortality. And this doesn't account for deaths that were logged simply as HIV/AIDS deaths, but they're actually due to CNS opportunistic disease, tuberculosis deaths that are logged generally as such, but are actually due to TB, meningitis, injury-related deaths that are actually due to head trauma, et cetera, et cetera. So 17%, probably an underestimate, probably a quarter of the global burden of mortality is due to neurologic disease. It's a little hard to see, but it's a top 30 list. Heart disease, the #1 killer worldwide. Stroke is #2. Road injuries, I'm going to presume if they were fatal, that there was some head trauma involved. Meningitis, Alzheimer's disease, falls 5 of the top 30, again, 17% of the global burden of mortality due to neurologic disease. And of course, many diseases that we care for, our patients don't necessarily have a shortened lifespan, but have disability, which affects their ability to live a healthy and productive life and contribute to their work and family. So looking at the global burden of disability, again, heart disease, #1, stroke, #2, but low back and neck pain, road injuries, migraine, falls, meningitis, Alzheimer's disease, just another day in general neurology clinic, right? 7 out of 30 of the top causes of disability, or 10% of global disability, is due to neurologic disease, and that's the highest contributor of any specialty. So we have a problem here, right? We have a huge burden of neurologic disease worldwide and a very inequitable distribution of neurologists throughout the world to care for patients with neurologic disease. So when I first started getting interested in global neurology, I wondered how a neurologist could get involved in this kind of work. And I saw a lot of surgical missions where surgeons were going to some region, as I mentioned earlier, and doing a bunch of surgeries or repairing a lot of cleft palates. And I thought that mission model might work for the surgeons if you have modern operating rooms and nursing staff and local doctors that care for patients before and after the surgery, but in neurology, it might not work. And I did see some neurologists going on so-called missions where they would go to some part of the world, see patients for a week, and then come back. And it struck me that that might be well-intentioned, but not ideal for patient care. Who would care for these patients when nobody was there? So early on when I was getting involved, I wrote this somewhat cheekily entitled essay called Neurology Missions Impossible, in which I argued that the mission model doesn't really work for us in neurology and proposed that rather we should think of ourselves as we think of our work here as consultants, that we would have no patients to see if it weren't for internists and emergency room doctors and pediatricians referring patients to us. And similarly, in global settings, we should think of ourselves as consultants to local doctors, local hospitals, local healthcare facilities. So I've been very fortunate over the last decade or so to be a consultant to Partners in Health. This is an NGO based in Boston that works with sister organizations around the world in some of the poorest regions to try to increase access to healthcare in those regions. So one of the founders of Partners in Health, Paul Farmer, one of Duke's most famous alumni, unfortunately passed away this past year. An incredible person, incredible figure, incredible mentor, and probably single-handedly saved countless lives throughout the world and through work that he began and collaborations that he had and mentees like myself that he inspired to continue his work and really created an incredible network of people involved in improving global health equity. So in Paul's memory, I'll have some quotes for you here from him throughout the talk. So one is one of his famous quotes is, "To me, it's about hope and it's about rejecting despair and cynicism. Those are the two biggest dead ends we've got, despair and cynicism." So if you look at these numbers, as I mentioned, countries in the world with 0 neurologists or 2 neurologists and think this is just an impossible problem to solve, we may as well give up. Paul always said that hopelessness is a privilege, and you have to have hope if you're going to try to assist in solving any of these problems. So working with Partners in Health, I've mostly been involved in Haiti, though I've done some consultation to other sites. So just some background on Haiti. I know you have a large Haitian American population here in North Carolina. Haiti occupies 1/3 of an island that is shared with the Dominican Republic, which is the other 2/3. And you see Haiti nestled here amongst a number of island vacation destinations, the DR, for example, Bahamas, Jamaica, Puerto Rico, but you don't ever hear of anyone going on vacation to Haiti. In fact, if you hear about Haiti in the news, you'll notice that it's always followed by the phrase, the poorest country in the Western Hemisphere. So much so that one Haitian journalist said that Haiti is the only country in the world with a last name, because whenever you see Haiti in print or hear it on the radio, it's followed by the poorest country in the Western Hemisphere. So what does it mean to be the poorest country in the Western Hemisphere? Well, to run the numbers, the GDP per capita, so the entire income of Haiti divided by the number of people in the population, is about a 20th that in the US. That wealth is, of course, not equitably distributed. So nearly 90% of patients in Haiti live below the poverty line of less than $7 a day. About 1/3 of patients in Haiti live in extreme poverty, which is less than $2 a day. Infant mortality is nearly 8 times higher in Haiti. And I recently gave this talk in Canada, and their numbers are actually much better than ours if you're familiar with infant and maternal mortality statistics in the US. So, and Haiti even 8 times worse. Maternal mortality over 15 times higher. And perhaps most striking, just for being born about an hour's flight from Miami, you're likely to live about 15 years less. So Haiti is a small island nation. We don't learn too much about it in US history classes, although the US is heavily involved in the history of Haiti. We won't have time to get into that today, but Haiti came to international attention in 2010 when there was a massive earthquake just outside the capital city of Port-au-Prince. Hundreds of thousands of people died, hundreds of thousands of people were injured, millions of people were displaced, and Paul Farmer made the provocative point that similar Richter scale measurement earthquakes in richer countries led to loss of life in the hundreds rather than the hundreds of thousands, and called this, to use a medical metaphor, acute on chronic effects of poverty. where there's extreme poverty, there's poor building materials, poor building codes, poor enforcement of building codes, that the level of devastation is much higher. So if you live in a house like this, as one of our patients does, and I should mention that all of the photos in here are used with permission of the patients for teaching purposes. So you could imagine living in a house like this. This is the inside of the house. Wouldn't take much of a tropical storm, let alone an earthquake, for people to lose everything. So this all sounds pretty depressing, and you might be wondering what a neurologist can even do here. And that's what I was wondering. My intern year was in 2010, so it began a few months after this earthquake, and I saw a lot of my senior medical residents and attendings going down to Haiti to help with earthquake relief from Boston. I had no idea if a neurologist could have any meaningful role in earthquake relief, but I said, when I'm a neurologist in a few years, I'd be happy to help in any way. And my colleagues said that they talked to their colleagues in Haiti, and they said, actually, as a resident, you can start coming right away, because they actually would like you not necessarily to see patients, but to come and teach. So in Haiti at that time, there was one neurologist for the entire country of about 11 million people, Haitian woman who had trained in Russia, actually, and come back to Haiti to practice, who unfortunately and very tragically died just a few years later. So there were 0 neurologists. This meant not only was it very difficult for patients to see a neurologist, or then ultimately impossible, but it meant that all of the physicians who were on the front lines practicing primary care had gone to medical school in a country with no neurologist to teach them neurology. So if any of you are involved in neurology curriculum development, you know that we're always fighting to keep our preclinical courses long, and they keep getting shorter and shorter and shorter. Imagine what the course would be like in a place where there are no neurologists to teach it, let alone to advocate for it to have an appropriate length and depth. So in 2012, my PGY 3-year, I made my first trip to Haiti. You see me here with a lot less gray hair, giving a lecture to a group of doctors and nurses on the diagnosis and treatment of neurologic disease. I was asked to visit a family medicine residency that was supported by Partners in Health, and to teach the neurologic exam, both so colleagues there could learn how to perform a neurologic exam, but also so we'd have a common language for me to help them with cases when I returned to Boston. And then I made bedside rounds with local doctors to help them with the diagnosis and treatment of their patients. And so here we arrive at our first dilemma, and I've covered a lot of ground in the last 10 minutes or so, but you might recall I said I would frame this talk in a number of dilemmas. And the first, for each dilemma, I'll give you a Haitian Creole proverb. I was asked to go to Haiti to teach, but I'd be remiss if I didn't mention how much I learned there over the years from my colleagues and patients, and my attempts to learn Haitian Creole, which is a language very rich in proverbs. And my colleagues knew I liked these, so they were always teaching me these proverbs. And this one is "Tout ça oué c'est pas ça," which translates literally as "all that you see is not that," or sort of like the English phrase, "nothing is as it appears." Now, my colleagues use this to describe their very complicated politics in Haiti, but I thought it was pretty apt for neurology, because on that first visit, there were really no labs beyond basic chemistries and no imaging beyond X-ray. So how do we learn and teach neurology with no ancillary data? We can all think of cases where we got a surprising imaging finding, surprising lab finding, worst case, surprising autopsy finding that completely reframes our understanding of a case, or just closes the loop on a case. How many dizzy patients that you were sure had a stroke that didn't, that you were sure didn't have a stroke that did, and you learn something from each case that you apply to the next case. How do you ever close the loop if you never know if your diagnosis was correct, if the patient got better because of your treatment, or just because of the natural course of their disease? And if you say, well, you won't have that data, but just develop some empiric treatment strategies and teach those, well, how would you know how to do that without epidemiologic data? So for example, we'd see patients with seizures not responding to first-line agents. The question came up, should we empirically treat them for neurocysticercosis? Well, how would you know if that disease is incident in Haiti without having neuroimaging to look for calcifications and other signs? So this dilemma was really encapsulated for me in a question I was asked over and over again in Haiti, and later when I spent some time in Malawi and East Africa. And that's, if a patient has a stroke and we don't have CT to know if it's ischemic or hemorrhagic, should we give them an aspirin? So I've paired this question with a picture here of an ambulance in Haiti trying to navigate a flooded dirt road, because hearing this question made me think about all the questions we're running through in our minds when we see a patient with a stroke here, about whether we can give them thrombolysis, take them to thrombectomy, what's our door to needle time. But in many parts of the world, there's no needle. And in some parts of the world, there's not even a door. And we're asking much more basic questions here. And it turned out, as I thought about this, I realized that this is probably the case for most stroke patients in the world, compared to our stroke patients here, where we can open the AHA, ASA guidelines and decide whether to open the ischemic stroke or hemorrhagic stroke guidelines based on the first thing that happens, which is a CT scan. But according to the WHO Global Atlas of Medical Devices, there are about 42 CT scanners per 1 million in high-income countries, and just 0.32 CT scanners per 1 million population in low-income countries. That's 3 per 10 million, that's 30 per 100 million. That would be like having about 100 CT scanners in all of the US, or about 2 per state. So this, of course, also, Atlas doesn't tell us if the CT scanners are functional, if the patients have to pay for them to use them, if there's a tech to run them, et cetera. So very limited access to CT worldwide, meaning that most patients with stroke and their doctors are not going to have a CT scan to know if the stroke is ischemic or hemorrhagic. And I started to wonder if this explained this epidemiologic statistic I had found when I was preparing my first lectures on stroke there, that only about 4% of patients in low-income countries are on aspirin after a stroke. Now, aspirin is cheap, it's widely available, it's a highly effective secondary prevention agent. And I started to wonder if many practitioners worldwide, like my colleagues in Haiti, would see a patient and they would say, we know the patient's having a stroke. We don't know if it's ischemic or hemorrhagic. Maybe we shouldn't give aspirin in case it's hemorrhage. We better do no harm. And I wasn't sure if that was the right answer. So I came back from this trip with this sort of bee in my bonnet and went to one of my stroke attendings, Dr. Sherry Cho, who was at Brigham and Women's at that time, now is at Northwestern. And I said, here's how I'm thinking about this. We probably need a population-based approach where we either say we're giving aspirin to everyone who has a stroke, or we're not giving aspirin to anyone. And my proposal would be to give aspirin to everyone, because most strokes are ischemic, fewer are hemorrhagic. We know we'd be benefiting the majority of patients. And then the 30-day mortality of an intracerebral hemorrhage in a high-income setting is around 30 to 40%. What do you think it is with no ICU, no intra-arterial blood pressure monitoring, et cetera? Morbid side of the argument, but probably it's not aspirin that's not going to make or break the outcome in that case. And Sherry said, well, your intuition is reasonable, but intuition is not as good as science. You should go across town and meet Brandon Westover and Matt Bianchi at MGH, who are neurologists skilled in computational modeling, and try to learn how to run a decision analysis where you could simulate a clinical trial to answer this question. So that's what we did. And I'm going to show you this in some detail because I found decision analysis to be a really interesting way of thinking about problems like this. That sort of trickled into my clinical reasoning when we're making complicated decisions all the time without data and going to some extent on our intuition and experience, but to try to put some framework around thinking about how we balance risk and benefit. So when you're building a decision analysis, the first thing you need to do is build a decision tree. And essentially, this would look like all the outcomes that could happen in a simulated clinical trial. I emphasize again, this is a simulated clinical trial because when we submitted this paper, the editorial office wrote back that we hadn't submitted the appropriate IRB approvals and patient consents. And we had to politely explain that no ones or zeros were harmed in the making of this clinical trial that was simulated on a computer. So essentially, we're doing a clinical trial, a simulated clinical trial, as if we're either giving all patients with stroke an aspirin or none of them. This would be our table 1, our epidemiologic data in this clinical trial, whether the patients had an ischemic stroke or an intracerebral hemorrhage. And then our table 2, so to speak, would be after an ischemic stroke, does the patient survive or die? Do they have a recurrent ischemic stroke from which they could survive or die? Do they have a hemorrhage in the subsequent year from which they could survive or die or make it through the year with no further events? And of course, all of these outcomes are influenced by whether the patient is on aspirin or not, increased risk of hemorrhage, decreased risk of stroke. Similarly, on the hemorrhage side, a patient could have a recurrent hemorrhage, they could have a stroke, and they could survive or die from any of these events. And each of these nodes here gets what's called a transition probability, which is essentially the relative risk of the next event occurring and how that risk is modified by aspirin. So these decision analyses are only as good as their data. So if you pull some of these from the literature, you see that a lot of those nodes are filled in with estimates, but we were lucky here. There's a lot of data for stroke. So for example, when we say on rounds that the risk of a second ischemic stroke after a first ischemic stroke is reduced by about 20% with aspirin, we're citing the antiplatelet trialist collaboration, which proved that aspirin is beneficial. That's why we do this at the expense of a small but acceptable risk of hemorrhage. Now, you might say no one would do the trial of giving aspirin to patients with intracerebral hemorrhage to see what happens. But there were at that time some retrospective series where patients who had an intracerebral hemorrhage went back on aspirin for their coronary artery disease or otherwise. And indeed, in those studies as well, it reduced the risk of another ischemic stroke at the expense of an increased risk of hemorrhage. So you plug all those numbers into your model and do what's called a base case analysis, where you sort of freeze the most important parameter. And the most important parameter for us is the percent of strokes due to hemorrhage, right? If 100% of the patients had ischemic stroke, we wouldn't need to do this. We'd give everyone aspirin. If 100% had an intracerebral hemorrhage, we wouldn't need to do this. We would not give aspirin. And we chose for this base case analysis a relatively high proportion of strokes due to hemorrhage. In high-income countries like the US, hemorrhage accounts for only about 10% of acute strokes. But in lower-income countries, such as this study that looked at different world regions, the percentage of strokes due to hemorrhage gets higher and higher, up to 34% in parts of sub-Saharan Africa. It's not known why this is. This may just be referral bias, that patients who have an intracerebral hemorrhage tend to be sicker and maybe more likely to make it to a hospital with a CT scanner. Or as I like to think of it, hypertension is free and diabetes, hyperlipidemia, and smoking costs money. So hypertension is a risk for both ischemic and hemorrhagic stroke, but maybe in poorer regions, hypertension wins out and increases the proportion of stroke due to hemorrhage, but we don't know why this is. So this, our most critical node here in determining how this plays out, we put at 34% to bias the model to the most unfavorable situation. So what did we find? Well, if you gave everyone aspirin, you'd reduce the mortality from just over 103 per 1,000 patients per year to just below it, not that significant. But you'd reduce the number of ischemic strokes by about 11 per 1,000 at the expense of just under 4 hemorrhages, so a net decrease of 7 strokes per 1,000. Again, doesn't sound very impressive, but if you consider that there are about 12 million strokes in low and middle income countries per year, our model predicts that if you gave aspirin to everyone, you decrease the number of stroke-related mortalities by about 4,000 and the number of recurrent strokes per year by about 85,000. We were vindicated a few years ago when someone actually did a clinical trial giving aspirin to patients after hemorrhage or restarting it that showed that it was completely safe. Of course, aspirin is just one small part of the care of patients with acute stroke, and yet the guidelines from the AHA and ASA rely on a CT scanner. So working with colleagues from Zambia, Nepal, Ghana, and some US-based colleagues that work in these regions, we developed some guidance, not guidelines since we don't have evidence, but guidance for elements like blood pressure and other shared management of acute stroke when it's unknown whether it's ischemic or hemorrhagic, and this came out just a few months ago in stroke. So when I'm asked this now, should we give aspirin to these patients with stroke? We don't have a CT scanner. I don't go through all these charts, graphs, curves, et cetera, but do say I think the default position should be to give aspirin. If you think the patient's having a hemorrhage, they have a headache at presentation, depressed level of consciousness, you think it's very likely to be hemorrhage, go ahead and withhold aspirin. But if you're not sure, or if it's unclear, the default position should be to give aspirin. So that's how we addressed our first dilemma. Moving on to dilemma 2. The proverb I'll give you here is Deyemon Ganmon. This proverb is beyond mountains, there are mountains. This is the basis for the biography of Paul Farmer. Mountains beyond mountains comes from this proverb, reflects the very beautiful mountainous landscape of Haiti, and also the fact that once you've scaled one mountain, you've solved one problem, you have another problem that faces you. And that problem was related to this neglected tropical disease. Anyone know what disease this is? Say again. Okay, we have a vote for leprosy. Yeah, so I've asked you a trick question by saying neglected tropical disease. This is a neglected tropical disease, but people always say leprosy because of the skin findings. This is epilepsy. These are the scars and burns and bruises of untreated epilepsy. And these two brothers and a sister who we thought actually had JME, had uncontrolled epilepsy and were falling into their cooking fires, falling off their motorcycles from their untreated seizures. So epidemiologists who study epilepsy talk about the epilepsy treatment gap, the percent of patients with epilepsy in a region who are inadequately treated. And in high-income countries, that's only about 10% of patients. But in low-income countries, it's about 3/4 of patients. And if you look at the more granular presentation of data in this paper, India is bringing this average way down, whereas in some countries, the epilepsy treatment gap is 100%, meaning not a single patient with epilepsy is adequately treated. So what was the story in Haiti? Why were these patients inadequately treated? Well, we saw patients coming to the clinic who were either on no treatment and were told they could not have their epilepsy treated without getting an EEG. We don't know where that came from, but there was someone doing EEGs in the capital city who had gotten, I think, a 6-week course in Cuba, was not a neurologist. We know that epilepsy training here is 4 years of residency, 1 to 2 years of fellowship, and 6 weeks is not enough to learn how to read EEGs. And so these were very hard for patients to get. It was sort of a physician running a side racket. The EEGs were always interpreted as epilepsy, even when they were not. But patients would spend a lot of time and money trying to get these EEGs, seizing all the way along the way. And then some patients would come on phenytoin 100, carbamazepine 200, or both phenytoin 100 and carbamazepine 200. So you might wonder why people weren't using the appropriate doses, but I'm sure if I was asked to manage a patient with heart failure and to dose their Entresto, I would have similar reservation about how to use these medicines. And my colleagues said this is a simple problem of education. If you can help us build an epilepsy protocol that's simple to use, all due respect to the epileptologists in the room, we only had phenytoin, carbamazepine, and phenobarbital, so the protocol's pretty straightforward. This is a little hard to see. In any case, it's in French. But we basically had a simple flow chart where we said, count the number of seizures, screen for side effects, start a medicine, go up, go down based on those 2 parameters. And on the other side of the piece of paper, we had the basic dosing schemes and titration schemes for these medicines. Now, of course, a protocol is only worth its weight in paper. And my colleague said, there's a hypertension protocol, diabetes protocol. All these NGOs are always giving us these protocols. Most of the time they end up in the bottom drawer. We should put together a manual where we would teach about the diagnosis and treatment of epilepsy and put the protocol sort of the centerpiece of the manual. Yeah, please. That's a good question. I should know that number, and I don't. After medical school, you can go directly into general practice. Internal medicine is considered a specialty. There's a fair number of general practitioners, but as in most poorer countries, most of the expertise and resources are concentrated in the capital, where about 1/3 of the population lives. And then as you get more rural, you have these health centers with 1 practitioner or 1 nurse per population. That's exactly right. Yeah. So there's very few specialists there, and there's no specialty training program. So most people leave for France or Canada to train and then don't come back. Yeah. That's exactly right. So as you'll see on the next slide, we developed this manual, but oh, I didn't hear that, but I will consider that a great honor. Thank you. I'll take it. So our colleagues there said, we have these manuals and protocols, and not everyone uses them. And probably what we should do are some trainings. So getting to your point, Dr. O'Brien, we decided to do a series of trainings for local primary care doctors, nurses, social workers, psychologists, community health workers, anyone who could come in contact with a patient with epilepsy. And we saw this in Partners in Health as a capacity building opportunity as well. You see me here facilitating an epilepsy workshop, and my colleague from Haiti, Dr. Dorlus here, sort of shadowing me. But by the end of this series of workshops, it was our colleagues in Haiti who we did has sort of a train the trainer model. They were running these workshops, and myself and colleagues from Boston were in the background here supporting them. So here I was a few years into this work. I've now graduated from residency on the faculty in Boston, and any chance I get running down to Haiti to facilitate epilepsy workshops and teach lectures and see patients. And my third dilemma here is that I was starting to feel a little bit spread thin. I would go, I was the only neurologist in the country, and people would say, oh, the nurse anesthetists want to lecture on coma, and the surgeons want to lecture on head trauma. I felt like I was sort of running all over the place doing a million little things instead of one big thing. And everyone likes lectures, and everyone was happy to have a neurologist there. I found the work very gratifying and meaningful, but I wasn't sure it was actually doing anything. So I was telling a colleague there that I felt sort of spread thin. I was trying to translate that into Creole and trying to figure out why we say that. I guess it's you don't have enough jam to spread on your toast or something. And they said, we have a proverb for that, much better than spread thin. It's Schengen kapie meli pakakuin on quatre chemins, which is a dog may have 4 legs, but it can't run on 4 paths at the same time. So around this time, Partners in Health opened a very impressive hospital in a rural and very destitute area of Haiti called Mirebalais. So Partners in Health had planned to open a small health center here in this region. No, Partners in Health is an NGO, and then Partners is now MGB, the formerly branded Partners collaboration between MGH and Brigham. No, Partners in Health is its own separate organization. Yeah. So after the earthquake, a lot of philanthropy was flowing into Haiti, and Partners in Health had been there for about 30 years. And so they were the beneficiaries of a lot of philanthropy. And they had planned to build this small hospital, but with the earthquake in Port-au-Prince, the main general hospital for the country was badly damaged. The nursing school collapsed in session, and with it, the next generation of nurses and their faculty. And there was a movement to try to decentralize some of the healthcare resources in Haiti, and Partners in Health had always worked rurally. So they went big and built the largest solar-powered hospital in a low-income country. I have no idea how they did this. Earthquake was in 2010, doors open in 2013, how you would even figure out who owns this land, how to get solar panels to Haiti, but somehow they did it. This is the publicity shot if you go to the PIH website, but let me show you what it looks like from my cell phone camera. This place looks like it fell out of the sky. This modern solar-powered building with modern operating rooms, an ICU, a CT scanner, which was very helpful for us. Here's a boy walking a cow to market. Zooming out, this is just a huge pile of garbage along the dirt road to the hospital. You see the little shacks that people are living in or selling things out of. So my colleague said, look, this is going to be sort of the flagship teaching hospital for all of Haiti. And so what we'd like you to do is concentrate your work here instead of going around to all these different places. And not only did Partners in Health open this hospital, but they started internal medicine, pediatrics, surgery, OBGYN residencies there. The first outside a major city in Haiti. There were residencies in Port-au-Prince and in Cap-Haïtien, the second largest city, but nothing rurally. And they said, why don't you focus on our internal medicine residents and give them sort of a neurology rotation. So when you're here, they're just with you and you're just with them. So that year, each time I was in Haiti, which is about 8 weeks that year in 2-week trips, I'd spend 1 week at this hospital and 1 week elsewhere. And there were 5 PGY2 medicine residents, the program being very small. And they would see all the patients that I saw, and I would see all the patients that they saw. And over those 4 weeks, we saw about 40 consults per week, which rivaled our service at Brigham and Women's. When there's one neurologist in town for a week, people put out ads on the radio, et cetera. People come from all over. I won't go through this in detail, but just to show you that in 4 weeks, we saw everything, every diagnosis you could think of, physical exam findings I had only seen in textbooks or on videos. And most importantly, the internal medicine residents got really good at neurology. So one of the best moments of this for me, I landed in Boston and turned on my phone, and there was a message from one of the medicine residents saying, got a patient here with bilateral INO, no lesion in the brainstem on CT, what do you think? I thought, I don't know too many internists that can diagnose INO and localize it. But even cooler, she was showing me a video, and the patient did have bilateral INO, but she was teaching her intern. See how this eye is abducting and the other eye is not adducting? See how there's nystagmus in the abducting eye? This is INO, it localizes to the MLF. We should be looking for a lesion in the dorsal brainstem. So my colleagues were very excited about this and said, you should start a neurology residency here because our residents are getting so good at neurology, we should have a local champion of neurology. And I said, well, I'm just one person. I'm not sure I can start a whole residency program. And they said, well, you're the one person who's working here in Haiti, so that should be enough. And I said, my chair gives me about 8 weeks a year. Maybe I could negotiate up to 12 for a year or two. That's barely even a quarter of the year. And they said, 12 over 0 is infinity. So that's pretty good. Yeah, go ahead. And I said, well, I'm just 1 year out of residency. I probably shouldn't be running a residency program. And they said, well, we don't see anyone else who's going to do it. And why don't you build yourself a team and let's get moving. And so my colleagues were trying to encourage me not to fall prey to what Paul Farmer called failures of imagination. He said to try to counter these failures of imagination, that the more difficult problems can't simply be left for a better day. What about the higher hanging fruit? Can we answer more of the need? Of course we can, with innovation, resolve, and a bolder vision. So anytime I gave a talk like this for a few years, anyone who shook my hand, I said, hey, would you like to come to Haiti? And I had about a 1 in 10, I think, conversion ratio to getting people at least to talk to me on the phone, and then maybe a 1 in 10 from there of people who would end up going down to Haiti. And we started not a residency, but a fellowship, so that we had residents who had graduated from medicine, family medicine residencies in Haiti, who would then spend 2 years with us, a very small program, 1 fellow per year. And as I said, I recruited faculty every AAN, every talk I gave, and we had about a dozen faculty who would spend between 1 and in some cases 10 weeks a year for recently retired faculty or people who work part-time. We covered about 26 weeks a year, but there are a lot of national holidays in Haiti. We brought the fellows to Boston for a 1-month rotation. We brought them to the AAN. So we covered about half the year. And part of the reason we did this as a fellowship is that these were already board certified physicians in Haiti who in any case were seeing neurology as internists. So when we weren't there, it wasn't as if we were leaving trainees unsupervised since they were doing this work anyway, but we had precepting locally about half the year and then staff cases by phone the rest of the year. So this was our first fellow, Dr. Rosabelle Francois. He started the fellowship at age 49, if you could imagine going back for training in your late 40s, early 50s. And he told me that part of his interest in this is that he had always wanted to be a specialist, and there were no specialty training programs in Haiti. I knew we were the first neurology training program, but didn't know we were actually the first specialty training program of any kind. So we had a running joke that if I had been a dermatologist, he would have become a dermatologist. And he said more or less that was the case. But already a brilliant, seasoned internist practicing for 2 decades, and became very quickly a brilliant neurologist. And in the first months there, when we were doing this, early 2016, we saw a huge uptick in cases of Guillain-Barré syndrome on the service, and discovered that that was the arrival of Zika to Haiti. And Dr. Francois wrote up our cases, submitted them to the AAN, and in his first year as a fellow, was invited to give a platform presentation, won an international scholarship, and the members of the committee who gave him the award said he was actually the first Haitian national to attend the AAN as far as they could tell in their records. Haitian American, Haitian Canadian, Haitian French, but never someone from Haiti. So not only a brilliant clinician, he's a brilliant teacher. Here he is teaching our second fellow, Dr. Boisgenet-Lamour. There's Dr. Lamour teaching one of the medicine residents on rotation with us. And then several years ago, Dr. Francois became our first graduate, the first neurologist to be trained in Haiti. We shook hands to congratulate him, then shook hands again to appoint him the program director, and continued to mentor him in that role. He graduated Dr. Boisgenet-Lamour the subsequent year. And here you see the first 4 generations of neurologists trained in Haiti, working in different parts of the country now. So one final dilemma for you here. I mentioned that we had a CT scanner at Mirabelais, which was very helpful for clinical care, very helpful for teaching. We've been teaching localization for many years now. We could show that it actually works when we get the scan. But it did create some challenging dilemmas. And the proverb I'll give you here with this dilemma is tout moun c'est moun, beautiful Haitian Creole proverb that means all people are people, or every person is a person. And the dilemma here related to this relates to the CT scanner. So we saw patients like this young man in his early 20s named Janelle, who developed progressive gait disorder, then progressive cognitive decline. And by the time we saw him was bedbound and mute, and had this huge intraventricular mass that we discovered on CT. We saw this young boy who developed normally until age 3, and then in an around-the-clock fashion developed spastic quadriparesis from one arm to one leg to the next leg to the next arm, who had this dorsal cervicomedullary cystic lesion. We saw this pastor who went blind in his right eye and then started losing vision in the temporal field of his left eye, was found to have this huge pituitary mass. So what to do for these patients? There was one neurosurgeon in Haiti, who's now the prime minister of Haiti, who did some spine surgeries, but we thought even if we brought a very skilled surgeon from Boston to do these cases in Haiti without the appropriate post-operative, perioperative critical care, these would be extremely high-risk surgeries. And I thought we should bring these patients to Boston to get the care that they needed. Colleagues told me, well, you know, it's not really cost effective, probably cost you hundreds of thousands of dollars to care for one of these patients. You could spend that money on building a whole new hospital or vaccinating the entire country, not cost effective. Some people said, well, it's not sustainable. Let's say you find some donor, you treat the first patient. You're not going to start a neuro-oncology service in Haiti. Stick to your aspirin thing, your epilepsy protocol, cheap, cost effective, sustainable, low-hanging fruit. You're not going to be able to do neuro-oncology there. But that is not how Partners in Health operates. And some of you may know one of Paul's most famous quotes, that the idea that some lives matter less than others is the root of all that is wrong in this world. And so Paul always argued that when people talk cost effectiveness and sustainability, it's rich people in rich countries making decisions about how to allocate resources for poorer people in poor countries, and saying that there are limited resources, whereas Paul always said there's actually more resources now than at any point in human history. They're just inequitably distributed. So working with our incredible colleagues in Haiti and in Boston, we were able to bring these patients one by one to Boston. This young man had a pineal parenchymal tumor of intermediate differentiation. I had not heard of it either. It's the rare cousin of pineoblastoma and pineocytoma. He's now ambulatory and talking, did not make a full recovery, still has major intellectual disability, but much better than he was before we met him. This young boy had a dorsal neuroenteric cyst. Hadn't heard of that one either. This is some gut tissue that goes the wrong way during development. Remember when the endoderm and the thing and they twist, and I don't remember either. But these are usually thoracic and ventral. This was the first one our colleagues at Boston Children's saw dorsal and cervicomedullary. It's a benign lesion. They plucked it out and he had a full recovery, just has a scar. His parents recently sent me this picture of him as a teenager now. They actually immigrated to Florida and he wants to be a doctor when he grows up. And then this pastor had just a good old-fashioned prolactinoma, although prolactin was greater than assay, hadn't seen that before. Unfortunately, could not restore any of his vision at this late stage, but we're able to preserve that corner of vision so he didn't go blind. And as Roshni mentioned, these patients taught me so much. They have incredible courage and faith to live with these disabling tumors under very difficult circumstances. And my colleagues in Haiti who advocated for them, I told you the happy endings, but there were lots of twists and turns and triumphs and tragedies and everything in between. So I wanted to write about their stories in this book. Of course, with COVID, our program in Haiti converted to how most of life converted itself to over Zoom. And then as some of you know, increasing violence in Haiti, the assassination of the president has made it unsafe to travel there. Sadly, lots of kidnappings and violence, and has made it very difficult to try to continue our program there. We do the best we can and are very glad we started when we did. And my colleagues encouraged me to get started before I was ready to. So we had trained a few neurologists before these barriers to travel and continuing our program as we had run it. But with a lot of extra time on my hands, no longer traveling 8 weeks a year to Haiti, I was looking for other ways to try to practice what I learned there in resource limited settings. So when the one neurologist for all of Navajo Nation in the Southwest retired, leaving 400,000 Navajo without a neurologist, I filled in for a few weeks a year until they hired someone new there. I do a lot of teleconsultation for Doctors Without Borders. I've never been deployed with them, although there are sometimes calls for neurologists if people are interested. These doctors work in some of the most difficult regions of the world. I get consults from Ukraine, from Sudan, from Afghanistan, and it's a real honor and privilege to be able to, from the comforts of our home and office here, try to provide them some help when they see neurology patients. And then most recently during the pandemic, I got involved with a group called the Clinical Problem Solvers. This is a group founded by some very creative internists at UCSF who have a podcast and a virtual morning report that they began during COVID. And I started becoming the neurology discussant and met a lot of extraordinary medical students from around the world who would come and present cases. Dr. Gabby Pucci presented me these very complicated cases. We published them. She's now a neurology resident at the University of Pittsburgh. Dr. Chiara Camacho and Marco Malaga, two amazing medical students from Peru. And I published this case they presented to me. Chiara, unfortunately, we lost to internal medicine, but Marco is now a first-year neurology resident at Baylor. And then coming soon to an ERAS near you, keep an eye out for Maria Aleman, a brilliant medical student from Guatemala, who's really helped us expand the access to the virtual neurology education that we use through this platform, and wrote this essay that was published in JAMA Neurology last year. And then, of course, we don't have to go too far from home to find health inequities. So our San Francisco VA, where I'm based, serves up to the Oregon border. People think San Francisco is Northern California, but there's about 600 miles left. And someone told me there are just 2 neurologists between San Francisco and Portland in private practice. So working with the VA to deliver care to our rural veterans, and then working for San Francisco General Hospital, which is our community safety net hospital in San Francisco that cares for many of our unhoused and undocumented patients in San Francisco. So with that, I'll leave you with one more Haitian Creole proverb, which is "Maam pil shai palu," many hands working together make the load lighter. One more quote from Paul Farmer, which is, "With rare exceptions, all of your most important achievements on this planet will come from working with others in a word partnership." I'll use that to thank my colleagues and mentors for training in the first 6 years of my career at Brigham and Women's, at Partners in Health, our colleagues in Haiti, the many faculty from all over the country who helped us in our neurology training program, some very generous donors in Boston who helped us care for these patients with the brain tumors who I mentioned, and then my new colleagues at UCSF who've continued to support my work. So thank you again so much for inviting me to Duke, and hopefully we have a few minutes for questions.
Excuse me, if any questions, people ask questions from the room, could you repeat those so the Zoom viewers can hear them?
Sure thing.
Thank you.
Yeah, great question. The question was, how did I get into this? And did I know going into residency that I wanted to do this? So yeah, just as you said, I'm part of the cliche generation that was in medical school when Mountains Beyond Mountains came out, read that book and said, this is what I have to do. A pretty cliched story, but Paul was a very effective ambassador for this type of work, and many people got interested. I had already been interested. Yeah, I think nothing in particular about my background. I went to medical school at Johns Hopkins, and so I think I saw a lot of very underserved population there, and probably my first direct exposure to people living in poverty and living in very violent circumstances, having grown up in a northeast suburb, and first exposure to health inequity and being kind of on the front lines. That probably planted a seed, I would guess. But it was really reading that book that sort of spun my compass north in that direction. I knew at that time I wanted to do neurology, and at first I thought there wasn't really a clear fit. Paul was an infectious disease doctor. Most of the people in Partners in Health are internists. And I was very fortunate. Some of us were talking about this last night at dinner, that I mentioned to a mentor who was a psychiatrist, I thought I should switch gears and maybe not apply in neurology. He said, well, I want you to look up the global burden of epilepsy and the global distribution of neurologists. And about 90% of patients with epilepsy live in low and lower middle income countries. And then the slide I showed you at the beginning with fewer known neurologists. And I said, but there's nobody doing global health and neurology, which was the case at that time. He said, that doesn't mean it doesn't exist. It means there's a huge need. So, and people in global health also said, follow what you want to do. You'll see any path. It's an all hands on deck approach. So we have pathologists that look at this, the slides we smuggle back from Haiti. And we have radiologists who read radiology for us in Haiti. So really any specialty, there's a lot of work to do. And so I went into residency knowing I wanted to do this, and particularly wanted to train in Boston, knowing that was where a lot of Paul Farmer's colleagues and disciples were, and that I could be side by side with them on the wars in Boston. And so when I had enough neurology to start trying to help out, they would keep me in mind. Yeah, thank you. Yeah, Maria.
So much available online, like whether it's telemedicine or online, that students even primarily use online resources. So how does that kind of change?
Yeah, the question was all the online opportunities now through Zoom or through open access medical education, how does that play into global health? When I got started working in Haiti around 2012, some people would say, why are you still going there? It's the 21st century. Can't you do this all over Skype? That was the platform at the time, seems old now. Or why would you need to go there? That seems so old fashioned. And I think telemedicine is very powerful. Someone even said, I don't know if you have a stroke robot here. Someone told me about these stroke robots that are sort of go and sort of do the video for the telestroke. So why don't you just get one of those and put it in Haiti, and you can just sort of do things over video. But I think part of my answer is I've learned that going there has still a lot of, it's old fashioned, but has a lot of impact, because so many people go in and out of Haiti or other places where a lot of people work. Uganda is another place where lots of US institutions have collaborations, Kenya. And it's not clear to people there who's coming once on spring break and who's really coming to collaborate. And I think it's even less clear when everyone says, well, I can do anything on Zoom, what sort of the commitment is and the long-term partnership. And even my first few times there, I felt I was committed, but people were appropriately skeptical that, yeah, then something will happen and you won't come here anymore. So I think going there is part of the equation, just to sort of set up any type of partnership, and then it can be supplemented by telemedicine and education. And I also think I do these consults through Doctors Without Borders, and as we know, when you get a consult here, right, someone says, well, I have a patient who's weak. Can you do the consult? They say, well, can you give me a little more information? And they say, very weak. You say, okay, why don't I come see the patient? Similarly, if I was calling a dermatology consult, I say, I don't know, it's red. Is it a macule or a papule? It's in the skin. That's as far as I got. Can you give us a hand? And so similarly, when I do these Doctors Without Borders consults, right, they will write, patient may have had a seizure, what do you think? Say, well, can you show me a video? Can you tell me a little bit more? And even if I said, well, can you go back and check this? It's very different to go there and teach someone how to do the reflexes if they've never worked with a neurologist before. And then, when you get a consult, this person knows how to check the reflexes, and not saying, well, I hit with my stethoscope and I'm not really confident in my, I'm not really sure. So I think once we had established a few people there who really could practice neurology, or at least the basics, then we could run with supplementing it with telemedicine. But as I'm sure you've seen, trying to do a first movement disorders consult over video is pretty hard. But in person, if you say this patient has Parkinson's, now I can treat you, over video. You don't have to come all this way. So I think it's both. I also just think being there, you get a sense of what the practice is there. So there's a lot of great and well-intentioned kind of tele consultation, but again, using that Doctors Without Borders platform as an example, sometimes I'm not available, and so they ask another neurologist, and you'll see someone has typed in, get an MRI with gadolinium, send the CSF to the Mayo Clinic for an autoimmune encephalitis panel if you have access to a PET scan, and then you come back and you say, oh, this sounds like TB of the spine. Don't do any of those things. And so I think being there, you get exposure to what's there and how people practice. And I'm often asked to do these global lectures, and you realize when you give a lecture that you don't really know your audience. So I could give a lecture on stroke, and then you hear from the questions, actually they knew all those things, and they had more practical questions or more sophisticated questions, and I've given sort of a very basic lecture. So I often recommend people give, if it's an hour lecture, no more than 30 minutes of slides, and then have case discussions or have sort of open for questions. And that really gives a sense of, oh, next lecture, maybe I should be talking more about this or frame it more this way. So I think it's both is a short answer. Yeah. Other questions, thoughts? Great. Well, thank you so much for inviting me to Duke. It's been a wonderful visit so far. I look forward to the rest of my day. And thanks again to Roshni. And thanks, I don't know if Tico is here or listening to for organizing all the logistics, and to Rich for inviting me as well. Thank you very much.